Good morning, everyone. My name is Tamil Kendall, and I'm the director of the Partnership for Women's Health Research Canada, also known as POWER. POWER is an alliance between the Women's Health Research Institute in British Columbia, the Women and Children's Health Research Institute at the University of Alberta, Women's College Research and Innovation Institute at Women's College Hospital in Ontario, and IWK Health located in the Maritimes. Our mission at POWER is to enable knowledge creation and mobilization, such as the event today, to improve the health of all women, trans, and non-binary people across the lifespan. We're supported in this mission by our sister organization, the Women's Health Collective Canada. And now I would like to invite Luana Listener, who is a research assistant with WICRI, the Women's and Children's Health Research Institute at U of A, and also a research coordinator with the Masquachese Waktuakwan Research Group, to start us off in a good way.
Thank you, Tamil. Good morning, everyone. When meeting in digital spaces, it's important to recognize the land where we are presenting from. This morning, I am presenting from Neasquayak Ermineskin Cree Nation, located in Treaty 6 territory in Alberta, Canada. Neasquayak is one of the 4 nations that make up the community of Musqueam. I come with respect and gratitude for this land that I am on today and for the people who have and do reside here. I would also like to acknowledge and honor the Indigenous peoples who have lived all across Turtle Island, which is known as North America, for thousands of years. While we meet together in this digital space this morning, I would like to acknowledge the importance of the lands which we all call home.
Thank you very much, Luana. And now just a few housekeeping details. Please, throughout the talks, put your questions in the Q&A in the chat. And thanks to those of you that let me know that we had started the webinar early. I appreciate that. So please put all of the questions that come into your minds into the chat, and we will answer all of those at the end in the moderated panel discussion that will be moderated by Shirley Weir. So I'd like to welcome Shirley. She's going to facilitate our session. She's the founder of Menopause Chicks, and she was inspired to begin this private online community, which now has more than 300,000 members because of her own perimenopausal journey and lack of easily available evidence-based information. Shirley is a 3-time author, podcaster, host, and TEDx speaker, has tweeted for Oprah, and speaks regularly to the media. She is a fierce advocate for midlife women's health information and empowerment. Over to you, Shirley.
Thank you, Tamil. Hi, everyone, and welcome. This day has been on my calendar for so long, and I am so grateful for the attendance, the registration, those of you that are joining live, those of you that are watching the replay, and especially to this distinguished panel that we have an opportunity to learn from today. So thank you. I know you have a lot of competition for where you spend your time today. So please take a minute to acknowledge yourself for carving out some space in your day to join us. I actually talk all day, every day about misinformation, misleading information, and the word I probably use the most is misinterpretation. So I wanted to begin with setting some context and some definitions around those words. But first, 2 invitations. One is, what if we were all to learn how our hormones work when cycles are regular? it would put us in a better position to make health decisions for ourselves when hormones are no longer regular. And what if all of us could pause before we make a health decision or share information that we've heard with others, and we asked ourselves, is what I'm thinking actually true? So those are my two invitations to you. I have three examples for misinformation, misleading information, and misinterpretation, just to help you explain. And you can find this on my Instagram page as well. But misinformation is defined as false information deliberately intended to deceive. So an example of that might be walking into a store and seeing a package on the shelf that says, if you pee on this stick, it will tell you which stage you are at on your perimenopause to postmenopause journey. The truth is, what that peeing on a stick will tell us is that there is probably $30 less in our bank account. And then misinterpretation occurs when we maybe take in information, but we don't seek clarification. And so an example of that might be hearing that there is a guideline for when we should have an inquiring conversation or an investigative conversation about the potential benefits of hormone therapy. And maybe we've heard that we should have that conversation within 10 years of menopause or under the age of 60. Now, that is true. That is a guideline, but it can often be misinterpreted to mean if your 60th birthday was yesterday, that it's too late for you. And also, it might be misinterpreted as that vaginal hormone therapy is not appropriate for you. So really seeking clarification about what that guideline means and refers to systemic hormone therapy can really put us in a better position to make the health decisions that we need to. And then, of course, there is misleading information. And that might be something such as vasomotor symptoms, which is the correct term for hot flashes and night sweats. Vasomotor symptoms can be mitigated if you cut out caffeine or spicy foods. And while we are all different and unique and our experiences are all unique, what we need to be asking ourselves is, are my vasomotor symptoms caused by drinking coffee? And if we just stop drinking coffee, will they go away? And so we have to be really clear, or we have to be concerned and curious about how we take in that information so that we don't just quit coffee and miss the opportunity to treat the root cause of vasomotor symptoms, which is fluctuating or declining hormones. And even more so, miss an opportunity to have a conversation with our health team about increasing cholesterol, increasing blood pressure, or even how we are going to invest for the next 3 to 5 decades in our bone health and in our genitourinary health. So this seeking clarity will put us in a much better position to make the health decisions that we need to now for our quality of life now and for the next 30 to 50 years. And with that, I want to welcome our first presenter today, who is Dr. Nesha Yüksel, a professor in the Faculty of Pharmacy and Pharmaceutical Sciences, College of Health Sciences at the University of Alberta, and a member of the Women and Children's Health Research Institute. And Dr. Yüksel is also the president of the board of directors of our Canadian Menopause Society. Welcome, Dr. Yüksel.
Thank you so much, Shirley. I'm just going to share my slides. Just give me 1 second. Hopefully you can see this okay. Thank you, Shirley. Thanks so much. Thank you so much for the introduction. I can't tell you what a pleasure it is to be here with the Power Seminar Series. I'm really excited for this seminar, and I'm also really excited about hearing from all of the speakers today. As you know, there's a lot of interest right now in menopause and more awareness on the issues of misinformation in menopause. and especially with menopausal hormone therapy. So these are my objectives today, and what I'm hoping to do is talk about the types of misinformation commonly seen with hormone therapy, describe why misinformation happens, and I'm going to spend quite a bit of time on why misinformation happens, and then look at strategies in combating misinformation for women and healthcare providers. Now, throughout this presentation, the term women is used, but I do respect that not all individuals who suffer from menopause will identify as women. So we are living in a time of great health misinformation. It's rampant. It's been called a major public health threat. And we know misinformation impacts health decision making. We have seen this, with the pandemic and vaccine hesitancy, among a lot of different things. And it causes confusion, and it can change how we think collectively. Now, misinformation on hormone therapy, I really want to stress, has been a real injustice for women. What may misinformation look like with hormone therapy? Tanya, a 49-year-old healthy woman who is perimenopausal, has read online that she will get a heart attack if she takes menopausal hormone therapy. Mira is fearful of using hormone therapy as all she has heard from her friends is that it will cause breast cancer. She's 51 years old, postmenopausal, and has no risk factors. And I'm sure you've heard this over and over again. Midori is wondering if her pharmacy sells a supplement called Menogon. She's heard on Instagram that's going to help with sleep, cognition, among other things, many, many other things, and will be better than hormone therapy. Sandra, a 52-year-old postmenopausal woman, is asking about bioidentical hormones. She's heard they were safer and would help balance my hormones. Now, I gave a number of examples, and we have many, many guidelines to support and guide us in menopause care. And these are just some of them, including the Canadian Menopause Guidelines from SOGC, published in 2021, 2022. I was the lead for one of the first publications. We have the North American Menopause Society, now called the Menopause Society, the NAMS guidelines from 2022, and IMS recommendations are a little old now, but they're redoing them as we speak. And most recently, just of last week, the NICE guidelines came out and were updated. So what do the guidelines say about hormone therapy? The Canadian guidelines are very consistent with the guidelines worldwide. The guidelines stress that hormone therapy is the most effective option for vasomotor symptoms, especially for bothersome vasomotor symptoms. We should be considering them first line. We also know that it can help with sleep, especially if fragmented sleep from night sweats, mood issues, vaginal dryness and frequent bladder infections, prevent bone loss and fractures, and improve quality of life overall. And hormone therapy right now, the recommendations is that it can be safely started, and this is to start in women who are less than 60 years of age or less than 10 years from their final menstrual period, especially if they have no contraindications. And I honestly focus a little bit more on the time since menopause than just the age. And women who go into menopause early or premature before the age of 45 should continue until the average age of menopause, to prevent those long-term health consequences from not having enough estrogen on board, such as cardiovascular disease, osteoporosis, and cognition. So we have guidelines, but what is the issue? And why is hormone therapy not being used more frequently? And this is from misinformation in hormone therapy. And I would like to refer to this as the perfect storm. It's really an anatomy of why misinformation has prevailed and has impacted the use of hormone therapy and has impacted women's health to today. But why? Why hormone therapy? And women are vulnerable during this time. They're looking for solutions. And we know there's a health gap in menopause and access to care. Many women are not getting the access to the care they need to adequately look at all the options and discuss all the options, including hormone therapy. There are only a few menopause clinics across Canada, and menopause may not be adequately addressed by primary care providers. And there might be different reasons for that, including the comfort level of the primary care provider with dealing with menopause. The other reason too is that the conversations about the risks and benefits of hormone therapy often require more than that usual maybe 10-minute time slot. And research, there's a research gap we know is underfunded for women's health in general. And even so, menopause, the area of menopause is even lower funding compared to other areas of menopause or other areas of women's health. And all of this is the result of the initial publication from the Women's Health Initiative, which was released in 2002. And I remember it like the day, like it was yesterday. I was in practice at the time in a menopause clinic. And unfortunately, the results of the findings about the increased risk of cardiovascular disease and breast cancer were announced early before it had gone through adequate peer review publication. And I know Dr. Lega will discuss a bit more about the WHI today and current thoughts on benefits and risks with hormone therapy. But I did want to talk about the disservice that's been done to women. And we're still dealing with it today. And many of you may have seen a really good article in New York Times, Women Have Been Misled About Menopause by Susan Dominoes. And this got a lot of publicity last year. And a lot of the discussion was how women are being misled about menopause, especially around hormone therapy. And a few years ago, there was a piece done by CMAJ Open, and they had this great infographics, which I tend to use a lot in presentations, and I wanted to highlight. There were a couple problems with the WHI. The investigators cited an increase in breast cancer as well as heart attacks in 2002, and this was publicized in the media. But these increases were not statistically significant. And the study focused on women over the age of 60. As you probably know, the average age was 63. But the results were generalized to younger women in their 40s and 50s who might be symptomatic. And what did we see? Decrease in hormone therapy use by 80%. And there were negative outcomes, increased risk of hip fractures, as well premature deaths in women who stopped early. And you may think, well, this must be different today. It's 2024, and it really isn't. This is a study we're just about to publish in Menopause, and it's the WARM study. It's an international cohort that was done, and it was a survey that was done, and we're just about to publish the Canadian cohort. And what I wanted to show you is in this cohort of women who had moderate to severe vasomotor symptoms, the use of hormone therapy was around 10%, and this is similar to other publications about hormone therapy use in Canada. And the most common reason for not being on hormone therapy or stopping was fear about long-term safety concerns. But misinformation directed at women is really nothing new. And I want to highlight some advertising from the 1960s and 70s and what this messaging is. So if you look at this advertisement on Premarin in the 1960s, soon after Premarin got a lot more interest in using, it says this lady is there, and it says help keep her this way, and you can see there's a younger woman, and it's the guy's happy keeping her this way, so she's smiling and happy. So really kind of towards the benefit for men, and it's quite patriarchal. And what about this advertisement from in JAMA? And this was in 1975, actually, and it was with Premarin as well. And it says, when women outlive their ovaries. So what happens when we outlive our ovaries? Are we supposed to die along with that? So you can see it plays on ageism. So let's look at the timeline for hormone therapy use. Premarin was marketed in Canada in 1941. But didn't get popularity until about the mid-1960s when Feminine Forever came out, which was published by Robert Wilson, and it recommended to cure menopause. And unfortunately, it actually said it as the tragedy of menopause, as you put it. It was very patriarchal, and it was patriarchy at its finest if you read the book. Then there was a decline when we identified that estrogen alone would increase the risk of endometrial cancer. Then it was identified if you add progesterone, that there was less risk of endometrial cancer. And then we saw a huge increased use in the 1990s. And that was around the time, late 1990s is when I got into practice. And we were using it for prevention of cardiovascular disease, among other things. And Premarin was the #1 drug prescribed. What happened in 2002? Drastic decline, as I mentioned. But look at 20 years later, 22 years now, but there's been a lot of follow-up data published about 20 years results. And overall, showing no change, really no increase in deaths and favorable outcomes with that. So, but the use has not changed. And if you look at the first time that bioidenticals came on the market, or was started to be describing, the first publicity was in 2004. That was the first real mentions of bioidentical, which is the same chemical structure as the human body's hormones. And this played a lot on the WHI results. So what happens when there is a lack of historical data for females in general? And we know that women have not been studied over the years in research, and the results of the WHI get misrepresented. What happens? Well, over time, this impacts our healthcare provider education. Our healthcare providers do not get adequately trained to deal with menopause or hormone therapy. And we see this, we're seeing this today. And this results in lack of access or adequate care or quality care. And that results in lack of awareness for women. And then women seek out their own solutions to help. And this is what's happening. They're turning to other solutions. And this is a study that we had published last year on regarding cannabis, that women were turning to cannabis to treat menopausal symptoms. This was a study we did in Alberta, and we had over 1,500 women who participated in the study, who took the survey, and over 34% were current cannabis users in this population. And 66% had used it some time. And the most common symptoms for cannabis use were sleep, anxiety, and joint aches, which a lot of these overlap with menopause. And just recently, we published the qualitative study. It was a mixed methods study overall, so this was the qualitative work. And I just want to highlight a few things from this, is that women express that they do not receive the support needed from healthcare providers to help manage their menopause symptoms. They found overall there's lack of information, limited role of healthcare providers, feeling stigmatized, and having to self-advocate for themselves. But this is what women are saying online, promotion for cannabis, for menopause. Everywhere you look, you can see that. And so I wanted to talk a little bit about the issue of online health misinformation. We know that nearly 80% of users look up health information online. And we know it's affected by search engine optimization. So you're seeing the same type of messaging that aligns with your beliefs because you might have clicked on something. And it helps us feel connected. When we feel vulnerable, it connects us emotionally. And what about the AI, and what about bots that help spread misinformation? And we know social media is a real area for health misinformation. It's rampant, but it can also provide good information as well. Social media provides a sense of community. We follow our trusted influencers, we trust them. And misinformation can spread quickly and allows for those echo chambers where we tend to select and share information that's related to the particular narrative, and we ignore the rest. Let's see. And what are the drivers of misinformation? Well, there's a number of reasons. They can promote own personal beliefs, sensationalize or misrepresent, but for the most part in menopause, it's profit-driven. The global market size for menopause, and this just came out this year, this report, was $16.9 billion US. And dietary supplements was 95% of that market. And in the report, it indicated that the growth of the segment can be attributed to the risks associated with hormone therapy. And by the year 2031, it's estimated to be 27 billion US. So let's take a step back and discuss why we believe misinformation. Online health misinformation uses tactics that make us susceptible to misinformation, and classic case is with hormone therapy. And this is a study we published on the promotion and marketing of bioidentical hormone therapy on the internet, and it was a content analysis. And I'm just going to touch on it very quickly, but what I wanted to mention is the majority of websites claim that bioidentical hormone therapy was safer than hormone therapy. But what was really surprising is the misinformation that was also on these claims. 28% of websites claimed hormone therapy to be protective for breast cancer. Not that it was a less risk, but that would actually protect you from that, which is very misleading. And these are some of the descriptors we saw in our analysis. And we tend to call these as glittering generalities. They're really marketing terms. You know, individualization of therapy. These are not going to be anything unusual for you. You're going to be very familiar with these. Natural, hormone imbalance, anti-aging treatment are some of the most common things that we saw. Obviously, others to sexual vibrancy, well-being, estrogen dominance, and physiologic. So let's talk about some of the theories. The human brain simplifies information processing through a filter of our own experiences and what we prefer, and we're prone to various confirmation biases. We tend to believe information that aligns with what we already believe, and we ignore information that challenges beliefs. And this is what we see with hormone therapy. If we've heard all of these things, these negative things over the years, it's really hard to change that narrative. And we're also more likely to believe information that aligns with our desired outcomes and emotions. Many of these beliefs are emotionally driven. Risk perception in health is one of them. You know, it's very true about hormone therapy. If we believe that natural is better, we're going to be more likely to pick something that we think is natural. And risk perception, once made, really takes a long time to change. And new information can further polarize those views. And we've seen this in many areas. So the more we hear, the more we turn away from that. And we mistake repetition for accuracy. It only takes 5 repetitions to believe a false statement, right? So if we hear over and over again, you know, that hormone therapy is bad or causes, you know, breast cancer or other things, we're going to start to believe it because we hear it over and over again. And the other thing that's really happening that we really need to be thinking about is any uncertainty or real diversity in scientific information by people who we believe as experts can lead to fear and mistrust in the system. So let's look at this. Let's see what's happening. And the hormone therapy pendulum keeps swinging. We're starting to see hormone therapy being recommended for chronic conditions online and social media, and you might have seen this by a number of influencers. What are your thoughts on that? Right now, we have a lack of evidence to recommend hormone therapy to prevent chronic conditions like cardiovascular disease or dementia, unless, you know, someone needs it for early or premature menopause. But of course, we have experts out there or individuals who are promoting certain things that are against current guidelines. And you may have seen this article in New York Times just last week, just published about Dr. Mary Claire Haver. And I thought the article was actually a very balanced view. Dr. Haver has a very large following on social media, over 2 million followers. And this comes from the article where online she's promoting, you know, hormone therapy, good thing to help with symptoms, but also preventing cardiovascular disease and dementia and contributing long-term health. And so to address these issues, the Menopause Society, previously NAMS, came out with their statement very recently about addressing misinformation about hormone therapy and not using it for long-term benefits such as cardiovascular disease or dementia in patients. And as well, the IMS, the International Menopause Society, in honor of World Menopause Day, came out with their white paper. And the reason they picked hormone therapy is because of all the misinformation out there on hormone therapy with these very differing narratives. And I would refer you to the paper that they put out. It's a really good resource. So just to end, how do we deal with misinformation? And this is what I tell women to look for. Identify those red flags. Is it promising to fix everything? is it using words that oversimplify and they're more marketing terms like natural and anti-aging? Is it using strong emotional language? Is it trying to grab you because they know what will help you? Is there experts? And even if there aren't experts, do they go or reference inside it? Even if they are, why isn't it consistent with expert consensus? Like, why is it different? And are they trying to sell you a product and claims that do not have that evidence? For healthcare providers, I often indicate to seek to understand, listen with empathy, establish a common ground. Do not focus on the false claim. Because it's emotionally driven, focus on how they may feel about the issue and help provide alternate explanations. So very quickly, some of the ways that we can deal with this, for example, is bioidentical hormone therapy natural? And it's often promoted as being natural, but this is a misnomer. It still needs to be synthesized from natural sources to be the same structure as in the human body. And many products also contain bioidentical hormones. Is compounded bioidentical hormone therapy safer? Not enough evidence at this point in time to support that. And is compounded hormone therapy marketed to be individualized? Is marketed to be individualized to your therapy? But all hormone therapy can be done to be individualized to help you. So this is where to go for more information. Include Canadian Menopause Society, Menopause Foundation of Canada, as well as NAMS and other sources. So it's just important to understand why misinformation happens and what counts as misinformation can change with time, with new evidence and scientific consensus. So thank you for that, and I'm going to hand it over to.
I think we have time for a question or two, if that's okay with you, Dr. Yüksel.
Yes.
Thank you so much. That was bang on. So many sound bites in there too that we can all take away. We are going to have a Q&A, everybody, at the end, but I think we've got time in our schedule. And I know Dr. Lega, who's our next speaker, is seeing patients right now. So this is a great opportunity. What you have identified for me is this perfect storm, which is the phrase that you used. And it reminded me of a conversation I heard at IMS a few years ago, which really focused in on the fact that risk often gets talked about without benefit. And usually breast cancer risk is at the top of that conversation. But what we don't hear as consumers is what the true risks of breast cancer are and how they relate to hormone therapy. So I'm wondering, for example, about alcohol and breast cancer. And can you speak to that? I'm sure it's a question that comes up with your patients a lot.
Yeah, no, that's a really good question. And one of the things that I often talk to patients about and women about is looking at modifiable risk factors. If you look at comparison, and I often show a slide, and maybe Dr. Lega might also be talking about this on what are the risks with breast cancer with hormone therapy. But I often show a slide and I show the comparison of use of hormone therapy for 5 years in comparison to drinking, 2 or more drinks every day, kind of thing, of alcohol, or, especially gaining a lot of weight. And obviously those are a greater risk or around the same risk as taking hormone therapy. So those are modifiable things that you can do something about. And yeah, and so I love showing that slide because it kind of really demonstrates the things that you can do that are the same kind of risk, as taking hormone therapy that we do. So I'm hoping Dr. Lega might be able to talk a little bit more about those. And if not, we can talk about more in the question and answer.
Yeah, for sure. I mean, as I mentioned, you had so many sound bites that came up for me. And one of them is like this use of the word natural as a marketing term. And I always like to remind members, like, natural hormones are the ones that our ovaries make. Anytime you take something and grind it up and put it in a plastic bottle, it's no longer natural. But we have a question from an attendee right now who would just like some clarity of definitions around non-bioidentical versus bioidentical hormone therapy. Can you
that's
provide
a
those
really
definitions?
good question. So Bioidentical refers, bioidentical, there's no actually medical term for bioidentical. Bioidentical is actually started as a marketing term. Bioidentical means the same chemical structure as our human body. So anything that contains types of estrogen that we have in our body, so estradiol, estriol, estrone would be considered bioidentical. And progesterone, it would be things like natural or micronized progesterone would be bioidentical. A lot of times, sometimes we'll refer to testosterone and DHEA as well in the, so it's anything that's the same structure. But a lot of our commercial products have what we would consider bioidentical hormones. So a lot of our estrogens have estradiol in them, for example. We have micronized progesterone, as well. So we have a lot of products that we consider bioidentical in our commercial. So we have a lot of options for women, which is great.
There is a huge menu of options, and I think it's really important if we can clarify too that those options are available from prescribers in Canada and every pharmacy that you go to. And that's where there's a gap between some of the ads that you threw up on your slides versus, and then we synthesize this information and think, oh, I need a special doctor. Oh, I need a special pharmacy. And the truth is that we do not.
Thank you. Thanks, Shirley, for that. That's wonderful.
Amazing. Okay, so I want to remind everyone that we, we'll do our best to get to as many questions as possible. We won't be able to address personalized because, of course, most of these questions require very individualized consults with your own primary care provider, but we'll provide direction as best we can. And I think I'm going to throw this next question at you, Dr. Yüksel, just because I used it in my opening comments about testing hormones in perimenopause and postmenopause. Can you elaborate on that?
Yeah, so for testing for hormones, especially in perimenopause, it's not really recommended. And the reason it's not recommended is that, during perimenopause, our hormones are fluctuating. And it's really hard to know if you do a hormone at a specific time, where that hormone would have been. So you don't really know. The other thing too is to keep in mind is that some of the symptoms we see is not from the level of the hormone, but it's the shift in a hormone. So how do you capture that in a level? It's very difficult. And same thing with postmenopausal. How would you know where people were supposed to be beforehand, right? When they became all you can say is you're postmenopausal and the levels are low, but you really can't, what is it going to tell you more? And the other thing, when we do hormone levels, we need to know that if we change the dose, that we are going to see and we look at a level, there's an association between that change and what response you're going to get. And we don't see that because everyone's so individual. We're all individual in how we respond. So it's the estrogen receptors that make a difference. It's not just the level.
That's an amazing answer. Dr. Lega just popped in to say that she's here, but we're still going to take a couple more minutes with you because I love this conversation. And one of the questions I have, it's kind of inspired by one of our attendees, is if you had a message, because we all have accounts on social media and some of us use those platforms more than other, but if you could speak to all of us with a platform, what is the one message you want us to take away from your presentation and your key messages today?
The key thing I want to take away is that, hormone therapy is an option for a lot of women who have bothersome symptoms. It's not for everybody, but if you have bothersome symptoms, it is an option. But it's for a lot of the symptoms. It can help with bone loss and fractures as well, especially if people are having symptoms. But being cautious on not listening to a lot of the kind of narrative that's out there and really looking at what experts are saying in consensus guidelines and following the guidelines. But I just want to reassure women that it is an option, especially if you're really suffering.
Yeah, and
among other options too. There are others as well, but
exactly. And stay curious. Ask the question
yes.
And then make the decision. Don't make the decision without asking all of those clarifying questions. Dr. Yüksel, I just want to take this opportunity to thank you for today's contribution, but for your leadership that you are showing your fellow physicians in this space, as well as consumers in Canada. We are so grateful.
Oh, thank you so much, Shirley. And what a pleasure. Thank you. I appreciate it.
Okay, so we are going to move to our second presentation this morning or this afternoon, depending on where you are. And I would like to welcome Dr. Ileana Lega, who is a staff endocrinologist at Women's College Hospital and a scientist with the Women's College Hospital Research and Innovation Institute. Welcome, Dr. Lega.
Thank you for having me. I was unmuted. So let me just pull up my slides.
Amazing.
Sorry, it always takes me a couple minutes, despite how many times I've done this.
Okay.
Okay.
Good to go.
Perfect. So thank you so much for having me. So I'm Ileana. As you mentioned, I'm an endocrinologist, which is a hormone doctor, actually, if you translate it out of Latin, in Toronto. And a big part of my practice is menopause care. And I'm also a scientist here at the Research and Innovation Institute. So I'm very happy to be here because I love dispelling myths about menopause. I do it all day long in my clinic, and I think it's so important. But just make sure we're all on the same page. What is menopause? So menopause is really a natural biological end to a woman's reproductive years. If you live long enough, 100% of women will go through it. So it's normal and natural. And it's not a medical condition. And that's sort of something that has been discussed a lot recently about medicalization of menopause, which is a whole different topic for a whole different day. But really, the bottom line is normal. However, many of the symptoms of menopause can be quite disruptive, quite debilitating, and can be treated. And I think sometimes there's a little bit of a misconception there. So Dr. Yüksel already went through a lot of this. I won't spend too much time, but it's a very complicated situation as to why all these myths exist. And some of them are really important to understand. So first and foremost is a knowledge gap. So we as women are really not prepared for this time in our life. There is up until very recently, as the pendulum has now swung, and it's actually all over the media and the news and there's books, there really hasn't been that much information for us. Along with that, there hasn't been much of an open dialogue either. Menopause has been a taboo subject, a subject with a lot of stigma associated with, really allowed few opportunities to discuss this, including with our mothers and our sisters and our aunts. Again, up until recently, women, even amongst themselves, were very, very closed and private about this time. The care gap, which I live in, I think is a major issue. So I think there's a significant care gap when it comes to women finding providers who are comfortable and confident in addressing menopause. And this has to do with the WHI, which I will also go into at least a little bit, but really has to do with the fact that there's a generation of doctors that just has not learned or been given exposure to treating menopause because of the fallout from the WHI. And that's a significant problem. Most medical curriculums have limited to no menopause curriculum, if you can believe it, including training programs such as family practice, gynecology, internal medicine. So that really creates a humongous gap. And it allows for perpetuation of some of these myths. And finally, there's the media, of course. Women, menopausal women for a long time have been very it's been the way they're featured in popular culture is extreme, focusing on sensationalized symptoms of hot flashes, but really ignoring the full range of what actually happens in menopause. So with that, I'm going to get to my 5 myths that I sort of thought deeply about, that I really think is most important to address today. And I think what's interesting about all these myths is that there's a small kernel of truth somewhere in the myth, and it really just, because of lack of context, as well of misconception, it just creates this a myth that it really needs to be debunked. So first and foremost is the idea that menopause is just hot flashes. And certainly, I mean, there's been enough now in the news and that we know this is not true. However, hot flashes are and night sweats are a significant burden for menopausal women. Up to 80%, if not 90%, will experience some sort of symptoms of hot flash and night sweats. And for about a quarter of women, these symptoms will actually be quite significant and debilitating. However, there's more than hot flashes, of course, and there's actually over 30 symptoms that are recognized as associated with menopause, and sort of going from top to bottom, a lot of them are really under-recognized and really can cause a lot of distress because, going through menopause, you don't know why you're feeling a certain way. So brain fog is really a very big symptom that more and more I see people presenting to my clinic with. It impacts their work, it impacts their ability to sort of perform. They feel there's word finding difficulties, difficulty with concentration that can be very embarrassing, unfortunately, but also very scary. Women think they're, in their 40s have dementia because some of these symptoms. And so an understanding that this is related to menopause can be very helpful. With that, there are very significant mood changes that happen. And a lot of these symptoms kind of coexist into sort of a stew of menopause, but there are also, sort of menopausal anxiety, depression can manifest or worsen during the menopause transition, which can, of course, be very debilitating. There's cardiac symptoms as well. So palpitations, so having irregular heartbeat can occur during this time. I've heard anecdotally patients calling 911 when they're going through menopause and they have palpitations. They think they're having a heart attack and they call the ambulance and nothing's going on. It's menopause, but they're just not aware of it. So it's very reasonable, of course, to be scared and seek care for that. Joint pain, or what's now called the musculoskeletal syndrome of menopause, really is a major entity that's getting more awareness right now. So there's significant joint discomfort that can occur during the menopause transition. A lot of women are actually misdiagnosed with rheumatological conditions during this time because it's not sort of holistically, the patient's not assessed to think, oh, this likely is related to the menopause transition. Of course, there's also periods becoming irregular, eventually stopping during this time, but also there are a lot more local symptoms as well, vulvar symptoms, vaginal dryness, discomfort, urinary symptoms. So a lot of symptoms, but many of them are not recognized. With these symptoms, there's also major changes that happen to the body because of the lack of estrogen. And I'm going to talk about this a little bit more, but it's really a time when cardiovascular risk and risk factors worsen quite quickly, and there's also significant bone loss. But the lack of knowledge has really negative consequences, as you can imagine. And this is from the wonderful surveys that the Menopause Foundation of Canada put out in 2022 and 2023. But about half of women feel unprepared for what's coming in the perimenopause and menopause, and that's obviously due to lack of knowledge. And that really leads them to feel very alone during this time and to sort of suffer in silence. But again, these symptoms and the lack of understanding and awareness of them has negative impacts on relationships. Up to 41% feel that menopausal symptoms has a negative impact on their personal relationship, and affects work as well, where women feel they really can't, their performance really suffers during this time. Oops, sorry. So knowledge is power. I mean, that's an old saying, but it really applies so much here, I think, in the menopause space. And being able to recognize menopausal symptoms as such can really empower women. I think the most important thing is to seek care and treatment from their healthcare provider. So knowing that a symptom may be related to menopause and that there may be a treatment for it is such an important tool for bringing them into that doctor's office and discussing with that doctor or primary or clinician that they have about if there are any symptoms and what they can do about it. It also validates these symptoms. There's nothing worse than thinking you have dementia at 45 or thinking you're losing your mind. And so it really does help reduce a bit of the fear, anxiety, and isolation when these symptoms are recognized as such, which then, of course, improves emotional well-being and quality of life during this time. And lastly, again, I think the knowledge really is important to proactively address modifiable risk factors, because as I mentioned, this is a time when cardiovascular and bone health can really change quite dramatically. So myth 2 is menopause begins when you stop having periods. That is the time, and that's what is considered menopause. So again, the kernel of truth here is that the official definition of menopause is that it occurs after you've gone 12 full months without a menstrual cycle. So in some ways, yes, the day you last had a period, in retrospect, represented when you entered the menopausal state. But menopause is actually a transition. It's a long transition and starts with the perimenopause, which is the time before that actual last period. And the symptoms and the changes can actually last for 10 plus years beyond. So it's a really long time when periods start changing, and that's due to the decline in ovarian function, which leads to decline in estrogen production. And estrogen really is the most key hormone that leads to a lot of the symptoms we see during menopause. And so again, perimenopause is a discussion for a different day, because that's an even less understood entity than menopause. But all that to say that it's long, the transition. There's some very interesting studies that have also shown, and this is a graphic of the severity and persistence of vasomotor symptoms, which are the most common menopausal symptoms. And you see here for about a quarter of women, they start minus year 9, so that's 9 years prior to the last menstrual period, and persist up to 10 years after menopause period. So all that to say, you can have symptoms for a very, very long time. And there's different trajectories of menopausal symptoms. Not everyone's menopausal transition will be the same. Not everyone's symptom burden will be the same. But it can, some women are lucky and have very few symptoms, and some have long and persistent symptoms. As I mentioned, and this is something I think that needs more, what should I say, media time, but it's of course not as sexy or fashionable, but it's this concept that when the estrogen levels decline, that has a very negative impact on a lot of what we say cardiometabolic factors, which means your blood pressure, your glucose, your cholesterol, all these conditions are risk factors when they're uncontrolled for cardiovascular disease. And this is sort of a hypothetical graphic, but essentially with normal aging, you have a steady increase in your cardiovascular risk factors. But if you see here during the perimenopause, so during the time that flanks the actual menopause, there's an abrupt acceleration of these accumulation of risk factors. And this again is directly due to estrogen, which leads to increases in blood pressure, arterial stiffness, worsening of the lipid profile, changes in fat distribution, which everyone who walks in my office has, in terms of more central obesity, despite no changes really in lifestyle, and decrease in muscle mass. So because we know that during this time of menopause transition, there's worsening of these risk factors, it's such an important potential window of opportunity for reducing cardiovascular risk in women, because let's remind ourselves, women will live half of their life after menopause. So it's really important to optimize and maximize well-being after then. So important things to consider during this time, which should be done at an appointment with a clinician, is really to identify cardiovascular risk reduction. That means looking for sex-specific risk factors for cardiovascular disease, which could be related to adverse pregnancy outcomes. We know preeclampsia, gestational diabetes, and other gestational outcomes are associated with increased cardiovascular risk in women. Age at menopause, so women who have earlier menopause may have a higher risk of cardiovascular disease, and also the severity of the vasomotor symptoms. I showed you that graph with the different trajectories of symptoms, but those women who have more severe and more persistent and long-standing symptoms are thought to have an increased risk of cardiovascular disease as well. So this is an important time for women to go in for their health checks, to get screened and tested and treated if necessary for cholesterol, diabetes, hypertension, and weight management. But it's also a very important time to talk about healthy lifestyle factors. And I know women hear this, all of us hear this all the time, but this is a very important time when this information should be reiterated and really specifically discussed. Exercise, we know the more is better. I tell my patients all the time, there's no better medication I can give you than exercise, which everyone loves hearing, of course. And really, I think more and more we know there's a lot of evidence for resistance training and muscle strengthening exercises. So lifting weights, or at least doing isometric exercises, squats, planks, wall sits, things where you're building muscle. We know it's so important for metabolism, for keeping you well, and for reducing adverse outcomes. When it comes to diet, it's the old-fashioned advice. You need to eat protein, you need to eat colorful foods, high fiber, whole grain, nuts, avoid processed foods, avoid sugar, and avoid refined grains as well. And of course, avoiding things that we know are so terrible, like smoking, and minimizing alcohol. Similar to the cardiovascular risks, it's also menopause a time when bone health really declines very rapidly. This black line here represents bone mineral density, and during the menopause transition, you can actually lose up to 10% of your bone mass. And again, this is normal with the decline in estrogen, but like the cardiovascular risk, this may represent a really optimal time for bone health prevention, such as making sure you're doing the right types of exercise and getting calcium, vitamin D. So myth 3 is an oldie, but a goodie. And Dr. Yüksel already spoke about it a little bit. But this idea, which still persists, but luckily less and less, that menopausal hormone therapy is dangerous. And as she already alluded to, it really, you can't talk about why women or people think that without talking about the WHI, which was the initial largest randomized trial to date and remains the largest trial to date to evaluate the safety of hormone therapy. And they recruited older women at the time. The mean age was 63 because that was, they really wanted to see if there was a goal for, you could look at preventing chronic diseases. And in fact, they reported an increased risk of stroke, heart disease, blood clots, and cancer, which given the way the media took it, given the way the results were reported, created mass fear and confusion that has been quite hard even now 22 years later to really step back from. There was misinterpretation of the findings, there was overemphasis of the risks, and really very importantly, a lack of discussion about the balance of risk versus benefit and all the benefits that for the right woman menopausal hormone therapy could have. And really what's most important, and which now we're very good at doing, is looking at these results by age. We know not all older women are the same. So women in their 50s are different from women in their 60s, etc. But because of the WHI, as was already discussed, there was a tremendous drop in hormone therapy use, the misinformation, but again, the care gap that was created by that cannot be overemphasized. Because of the WHI, the topic of hormone therapy and menopause fell off the curriculum in many, many institutions, including myself. I am a post-WHI trained physician, and it's really been after I finished my training that I got this information because it was not taught to us up front. Since the initial WHI, there have been follow-up studies that have really tried their best to undo what was done with the initial studies. And they have found consistently that in younger women, so in women who are 50 to 59, which are newly kind of menopausal women, there is no increased risk of heart disease or stroke with hormone therapy. And in more so, they've done some longer launched 17-year follow-up study where there's no change in mortality either, despite some of these initial signals. There's been other studies since as well, smaller than the WHI, that continue to reinforce and confirm that in young women within the first 10 years of menopause, there may be a beneficial effect on cardiovascular outcomes, but at worst, it's a null effect. There is no increased risk. So that's something that's really been persistent, and we've been trying a lot to undo because people still have this reflex instinct to think that hormone therapy causes heart disease. The question of breast cancer was brought up. I have this in my one slide on it. But I think, again, it is important to recognize that there likely is a small increased risk of breast cancer with hormone therapy. And that is the main reason why it should not be given to everybody, because there are risks with hormone therapy. However, having said that, the risk is actually very low and the absolute risk is very low. If you have to put a number on it, it's a very hard thing to do. We say it's about 2 to 3 additional cases per 1,000, but with 5 years of use. So what that means is that women who may only need it for a few years because that's the peak of their symptoms, we don't think there actually is an increased risk when it's a short-term use. And the risk, again, this was discussed earlier, is very similar to the risk associated with having a sedentary lifestyle or having about 2 alcoholic beverages a day, which are modifiable risk factors that many women accept without thinking. But yet when it comes to hormone therapy, it's a very different reaction. The other really, really important thing to mention is that these risks are really derived from the WHI, which used hormones, Premarin and Provera, that we don't use as commonly or almost ever anymore. And so the risk with newer formulations likely is much lower. We just don't have those confirmatory studies yet. So knowing how to choose your hormone therapy can really mitigate the breast cancer risk. So the final piece on the myth 3 is that really menopausal hormone therapy is safe for the vast majority of women. So in my opinion, all women should have a discussion with their providers about whether or not they are candidates and it makes sense for them. There are contraindications, of course, which I've summarized here from the SOGC guidelines, and they really are relatively rare, mostly related to having a personal history of breast cancer, having a personal history of heart disease or stroke, and of course, liver disease as well with some other variations. But again, overall, it's a relatively small population that is not at all a candidate. This one I love. It's new, this myth. And again, it was alluded to with by Dr. Yüksel, and has a lot, I think, to do with social media, that all women, no matter who, should be treated with menopausal hormone therapy. And there are a lot of claims circulating that it's like an elixir of youth. They'll keep you young. We're kind of going back to sort of what Dr. Yüksel showed us with those horrible advertisements from early on. But again, there's these claims that it prevents Alzheimer's, it prevents heart attacks, it reverses aging, it reverses menopausal weight gain. So I actually commonly see women referred to my practice who feel they're missing out. They're lucky, they're going through the menopause transition well with minimal symptoms, yet they feel they're missing out because they're not on hormone therapy. So the truth here is that there are very specific evidence-based benefits of hormone therapy. Hormone therapy is amazing at reducing night sweats and hot flashes. It has very good data for helping bone density and reducing fracture risk. In the US, it's actually approved for prevention of bone loss. In Canada, the guidelines say it can be considered for the treatment of bone osteoporosis. It also improves local symptoms of menopause, sleep, joint pains, and anxiety and depression that occurred during the transition. Again, these were already reviewed, but there are specific guideline indications for treating with hormone therapy, and they really have to do with the age of the patient, being newly within menopause, and having symptoms, vasomotor symptoms. Those are the main indications. Again, when it comes to treating patients, I like this concept that you don't treat the menopause, you treat the menopausal symptoms. So if you have someone in front of you who is not having significant symptoms that can benefit from hormone therapy, there's no indication or benefit likely for the hormone therapy. So you want to assess the severity of the symptoms. You have to realize that not all the symptoms are likely to benefit from hormone therapy. And again, it's not prevented for disease prevention. And you do want to be careful in women who are beyond the guideline specifications. It's not an absolute no, but you just want to be more careful. And I know I'm running out of time. I just have one more myth I want to get to. And it's the myth, again, that was alluded to, that you need that special menopause diet and that special menopause supplement. The market is chock full of all sorts of things that have menopause in it, that are deemed to be the cure you need for menopause treatments and to optimize your menopause transition. And this is really the truth here, that this is a business and an industry, and you have to be very, very careful. The supplemental industry is very poorly regulated, and most of their claims are not backed by science. So unfortunately, it's a buyer beware kind of environment, but you just, I just want to make sure that is clear for people. So when it comes to diet, is there a menopause diet? No. There's no menopause diet. There's just the good old-fashioned recommendations for healthy eating, which I already reviewed, which is the protein, the fiber, the whole foods. And similarly for supplements, no. And in fact, the Menopause Society did a very thorough review looking to and got published guidelines on non-hormone therapy, including dietary supplements, and they didn't find any to suggest, because there's just not robust enough evidence supporting their use. It really comes down to calcium and vitamin D. So these are my sources, which are very similar to Dr. Yüksel's sources for good information. Some of them are clunky because they are medical societies, but they all have patient-facing resources. I also really do like Jen Guttner, who is the one social media person I think is very good at sort of cutting through the literature and providing evidence-based information. And then that's it. So thank you very much. So really we know there are significant gaps in menopause which lead to this misinformation. Women really need to empower themselves with knowledge to be able to make informed decisions about their health and what works for them. And really, menopause care needs to go beyond hot flashes to focus on long-term outcomes. And again, I do think it's very important to engage your healthcare providers in navigating this transition. So thank you. And sorry, I know I went over a little bit.
You're all good. Thank you, Dr. Lega. Can you stay for a minute?
Sure.
Thank you so much. Earlier this year on International Women's Day, you stood on a stage, you and Dr. Sheila, and told the crowd that we were about to spend more time talking about menopause than you and your colleagues had at medical school. I think we're doing the exact same thing here today. So thank you for the time and the expertise that you've been able to share with us. Last year, you published a paper for the Canadian Medical Association, which I've been able to refer to many times. But we're sitting here almost at the end of 2024, and many consumers are still leaving their health appointments feeling dismissed or disappointed. And so, what piece of insight can you give us to help us dispel some of these myths you've shared with us with our healthcare providers?
Yeah, you're right. It's still a big problem. I hear that a lot. One thing I tell patients who tell me that over and over is, your relationship with your healthcare provider is a relationship. It should be a back and forth. So it's very reasonable to go with them with information that you hear and say, look, you don't want to tell your provider what to do, but telling them, I heard this, I'm wondering that, do you think it could be that? I actually have anecdotally one patient who told me she had informed herself, she realized her symptoms were menopausal. She went to her primary care provider and said, I think it's menopause. How do you think I should treat it? And her physician said, I'm not too comfortable dealing with this, but I will look into it and get back to you. And a week later, they had a follow-up appointment. And then the physician learned with the patient, and that's okay. And that's very reasonable. Of course, as long as you have, a clinician who's willing to work with you, which I hope you do. But I think there should be no shame in recognizing and saying that to your provider that you want them to explore this with you. And I think that because I do feel that a lot of menopause care should live in primary care. It really is not a specialty problem. It's not a problem, but it's not a specialty condition that needs, because that won't work. There's not enough specialists who will be able to provide care. And really it should be within primary care. But we're working on it. It's a work in progress. And I think being patient with your primary care provider is important.
Yeah, that's an excellent response for me to take away to the Menopause Chicks community. So thank you so much. And to even quote a phrase we used during our last presentation is we are living in a bit of a perfect storm right now where we have this, multiple messages coming at consumers every day. And doctors are feeling that pressure, but they also have so many other roles and responsibilities in their practice and in our community. So be informed, be confident going into that conversation, and also be patient. Thank you for that. I think that probably if I was to pull out one of the biggest misinterpretations I'm seeing recently from your presentation, it's been around cardiovascular health. Because women are hearing, oh, your blood pressure is going to go up, your cholesterol is going to go up. And they're also misinterpreting the fact that if they have vasomotor symptoms, it might mean they have cardiovascular disease. Or if they don't have vasomotor symptoms, that they're okay. So could you speak to that?
I mean, there's still a lot of research that needs to be done to further clarify that. So certainly we know, regardless of your symptoms, it is a time, as I showed you, where cardiovascular risk factors do worsen and increase, really just due to the lack of estrogen. Whether or not you have symptoms from the lack of estrogen is different from whether or not it's going to affect your blood vessels and your heart and your pancreas and all that. So I think that piece is key, regardless of who you are and how you're experiencing it. It is a time when you really want to try as best as possible to optimize how you're living your life and do so in a healthy way, which reduces your cardiovascular risk. However, women who have more significant hot flashes do seem to be at increased risk. So either there is something else about them that has caused them to have more symptoms that also increases the risk, or it's really an independent predictor. So I think knowing that you have, or having as a physician, knowing your patient has that, really should be a little red flag for you to be extra vigilant with that person in terms of really optimizing them and making sure you're screening them as regularly as possible.
Amazing. We know you have a busy day. Hopefully you can come back and join us for the Q&A, but thank you very much for your contribution to this session today. And now it's my pleasure to welcome back Luana. Luana Listener is a research coordinator with the Muscatchees Wauwatowan Research Group and a member of the Women and Children's Health Research Institute. And it's our pleasure to welcome you back. Thank you for sharing your expertise with us today.
Thank you for that introduction, Shirley. Okay, Danse Dawia Gakiao Kititam Scott Noel. Hello, how are you? I welcome you all to the session Community-Led Menopause Research in Musquechies, an Indigenous community. It is an honor to present on behalf of the Soquetejeo Strong Heart Group and to share the work that we did with the women of Musquechies. Musquechies is a Cree First Nation community that's made up of 4 bands: Louis Bull, Montana, Samson, and Ermineskin. Pigeon Lake is a community that's south of Musquechies, and it includes all members from all 4 of the bands of Musquechies. It is located in central Alberta, about 96 kilometers south of Edmonton in Treaty 6 territory. Musquechies is where I call home, and it's been a blessing to work as a research assistant with my community, for my community on this valuable work. So just for a little bit of background, menopause has received little attention in Indigenous health research. There are still gaps in understanding how cultural differences can shape the menopause experience, considering the impact menopause symptoms can have on quality of life, not only for the affected women, but also for their spouses and other family members.
Pardon me, Luana, for the introduction. If you're wanting to show us slides, we're not seeing them right now.
Oh, no. Okay. One moment. Thank you.
But that was all very clear without the slides. Thanks a lot.
Okay, can you see it now?
Yes, that's perfect.
Okay, thank you, Tamil. Okay, so where was I? Okay, so in response to the wish of women to start a dialogue in the community on menopause issues, we undertook preliminary exploratory research with Cree women living in Musquechies. Our research engaged the women in workshops to explore their own menopause experiences. Our community-based participatory research goals were to engage with women community members to explore in a series of workshops their perceptions and experiences on menopause and the impacts that the symptoms have on their quality of life. The subsequent knowledge translation efforts responded to the findings of the initial research with the goal of benefiting the community members by raising awareness and increasing education about menopause symptoms and experience. Historically, research was done on Indigenous communities, and the results were published with little or no benefit to those communities, and they often portrayed Indigenous peoples in an unfavorable light. With that in mind, we sought to do our research in a good way that was meaningful and respectful for everyone that was involved. The Tri-Council Policy Statement Guidelines and OCAP principles help ensure that research is developed in close collaboration with communities and that the data and findings are used for the benefit of those communities. These principles guided the development and conduct of our research and ensured that the community was involved in leading the dissemination of the findings in a meaningful way. We employed a community-based participatory research approach to design and implement this research, responding to the desires of Musquechies women to raise awareness of menopause symptoms and their impact of quality of life. Indigenous CBPR principles acknowledge Indigenous ways of knowing and ensure that data and outcomes are interpreted in a culturally sensitive and contextually appropriate manner. Our research is community-led, strengths-based, and includes elders and community members as experts. The Soquetejeo Strong Heart Advisory Committee was established early in the development of the research process. The advisory committee involved community members and elders, Musqueam's health services staff, and researchers from both the University of Alberta and the University of Calgary. The advisory committee reviewed the research findings, and they decided on each step of the research process to ensure that our research moved forward in a culturally respectful, relevant way. The study was approved by the University of Alberta Health Research Ethics Board, which adheres to the recommendations of the Tri-Council Policy Statement, research involving the First Nations, Inuit, and Métis peoples of Canada. Our research aimed to involve women in menopause transition age from any of the 4 nations in Musqueam's who were interested in sharing their experiences with researchers and other women. The workshop started with an introduction about menopause, and the women were invited to share their experiences, including symptoms and techniques they used to manage them. The discussions were organic, informal, and very interactive, with participants guiding the direction of the conversation. To ensure that the issues related to menopause research were included, a discussion guide was created for the workshops. Because the discussions were led by the women's own experiences, they covered a very broad range of topics associated with menopause, and feedback was provided by participants in follow-up meetings if needed. So 4 themes emerged from our menopause workshops, and the first one was menopause symptom experience. Participants talked very openly about their own experience of menopause, their experience of menopause onset, and symptoms varied widely. During one workshop, benefits of menopause were discussed. One woman described how activities were less restricted post-menopause. A major constraint during menopause was not being able to take part in ceremonies such as sweats and round dances while having one's moon time or menstruation and 4 days afterwards. The second theme to come out of the workshops was menopause knowledge prior to their own experience. Most participants felt that they had not acquired enough information about menopause and the symptoms before their own experience, because menopause was not talked about by their mothers, their aunts, grandmothers, or even by their doctors. These choices may be partly due to the loss of a dialogue between generations about female topics as a result of residential school and colonization that have deprived women of their status. Several women reported that their mothers, when asked directly about menopause symptoms, declared that menopause was not a problem. It was really nothing, or they didn't say anything and they endured their symptoms stoically. The women discussed whether their mothers were in denial of menopause symptoms, viewed them as the consequence of a natural, invariable stage of their life, or whether they had really forgotten about their symptoms. One woman mentioned that in the past, menopause symptoms may not have been as obvious because people were so busy. They were too busy to deal with their symptoms, and sweating was usual when women were occupied doing physical work. And traditionally, the women were the ones who put up the teepees, so we did a lot of really physical work back then. So that's a really good point. Observing other women experiencing menopause has helped some women prepare for their own change of life. The third theme to come out of the workshop was menopause symptoms management. While going through their own menopause transition, some participants were prepared to deal with the symptoms, and some participants mentioned exercise and using traditional herbs and remedies to manage their symptoms. The last theme to come out and to emerge from the workshops was the impact of menopause on family members. A major concern for workshop participants was the effect of severe symptoms on their family relationships, particularly their partner relationships. Participants noted that other family members could also be affected by menopause symptoms. Several women felt that they were not understood by family members, especially because of their unpredictable mood swings, depression, or anger. These symptoms could cause strife within the family, particularly if the family members did not understand the cause or if they were undergoing their own hormonal changes, such as puberty. Participants felt that they can only now relate to earlier uncomfortable observations of mothers, aunts, or grandmothers' symptoms. One woman said that she told her children, "Don't get scared of me, I get scared of myself." Participants felt that if male partners and family members learned about the effects of menopause, they would be more understanding about changes to women's behavior as they go through the transition. And they believed that there was a need to educate spouses, children, and other family members about menopause symptoms. One participant stated, "This is important. I want my family, my daughters, and my granddaughters to know what physical changes are coming." There were two priorities that came out of the workshops, and these were really important to the participants as well as the elders. The first priority was for participants to educate themselves, to learn about the menopause process, to learn about what options are available to them in the community, and also to work towards solutions for themselves. The second priority that emerged was the importance of educating others. Participants noted that menopause acted as a catalyst for family conflict and breakdown. And this is an important point to consider when living in Musqueam because the housing is it's really short and it's not sufficient. And there's often 3 or 4 generations living in one home. Participants wanted to be able to communicate with family members and others about menopause to help family members understand what they were experiencing, to educate others on the spiritual, mental, emotional, and physical symptoms, as well as to inform any misinterpretations related to menopause. The key finding was the need for increased knowledge and awareness about menopause within the community. Knowledge translation was planned by a group consisting of 2 elders and 6 women community members with the support of Musqueam's Health Services staff and a University of Alberta researcher. The KT group met several times. During the first meeting, the group decided that to first develop menopause pamphlets describing symptoms and coping strategies to improve understanding between family members and what women experience during menopause. During the second meeting, we decided to develop separate pamphlets for both men and women. And in the third meeting, we finalized the wording of the 2 pamphlets and we agreed on a Cree word for the name. So the name is the Soquetehel Strong Heart Group. And we felt that the word Soquetehel really illustrated or exemplified the women and their compassion for this project and that they demonstrated having strong hearts. 2 low-tech culturally sensitive pamphlets were developed for use within the community, and they were based on the findings of the workshops. The wording and layout of both the pamphlets are very similar, but are targeted for 2 different audiences. So one for men and husbands, and the other for women and other family members. Several sections are designed to help understand about the change of life, i.e. menopause. So what are the symptoms of the change? What actions may help someone during the change. For example, engaging in exercise, talking to an elder, or taking traditional medicines. What can you do to help someone through the change? For example, offering support and love. And what happens after the change when the hormonal fluctuations have calmed down? With these few simple pieces of advice, the goal was to increase understanding and reduce anxiety and stress about the changes associated with menopause. Following the development of the pamphlets, copies were distributed through Musquecheese Health Services and in the health clinics. In addition, the Soquetejel group had taken pamphlets to numerous community events in the four nations of Musquecheese and also in Pigeon Lake. Here's a copy of the pamphlet that's designed for women and other family members. And then here's a copy of the pamphlet that's designed for men. While handing out these pamphlets in the community, women would often get very excited when they find out that we have information pamphlets related to menopause that are specifically for men. And they express that they want to share this information with the men in their homes and in their families. Our study involved both exploratory research and KT, so knowledge translation of the research findings in the communities of Musquecheese and Pigeon Lake. The study provides information on the perspectives, beliefs, and management strategies for menopause of the Cree women of Musquecheese and Pigeon Lake, adding to the very limited published work on menopause in Indigenous women in Canada. Talking about female issues, including menopause, is still considered private in many Indigenous communities. An important outcome of our research has been giving women a voice and starting a much-needed dialogue to raise awareness and understanding of menopause in the community. The Soquetejel Strong Heart Group consists of community members, elders, and researchers, and it was formed to give the women a voice to overcome their reluctance to openly discuss menopause and to implement culturally appropriate strategies in order to raise awareness and provide educational opportunities about menopause symptoms for the benefit of the whole community. So I would like to express our gratitude to the participants and the people of Musquecheese and Pigeon Lake communities who were involved in this study and who shared their experiences, stories, and perspectives related to menopause with openness and compassion. I would also like to thank the Soquetejel Elder Advisory Committee members for their wholehearted commitment to this research. Margaret Montour, Phyllis Potts, Rose McEnroe, Linda Omuso, Yvonne Saddleback, Rosie Roan, and Mary Munoz. The 7 elders were an integral part of the work that we did, playing essential roles in guiding and supporting the research team and community members, contributing to every stage of the research from the initial discussions about the workshops, attending the workshops themselves, and providing personal mentorship to the researchers. They provided an inspiration for this work. And I would also like to acknowledge Dr. Sue Ross for her valuable contribution to the work as well. Thank you.
Thank you, Luana. I would like to personally thank you and express gratitude on behalf of all of us today for leading this work. This is so important. Do you have a wish for the future? Where would you like to see this go, and how can we best support this initiative and your work?
My wish would be for this work to continue on and to become self-sustaining for the young people in Indigenous communities to know about menopause and the support that can come from elders and the community. Thank you.
I think that's we're on the right track with you taking this initiative and also showing us how impactful work at a community level can be for all of us. So we all have our own communities to share this information with as well. Thank you so much.
Thank you.
We are going to transition to our fourth and final presenter for today. And I just want to remind you that after our next presentation, we will be moderating a Q&A. We have lots of questions in the queue, which is not a huge surprise, but hopefully you can stay for 10 minutes or so at the end to do that. But before we go there, it is my pleasure to introduce Dr. Marina Ashade, and we are going to talk about the results of the HER-BC study, which was just released on November 1st. And HER-BC is the health and economics research on midlife women in British Columbia. So welcome, Dr. Ashade.
Thank you so much for having me. I'm sorry, I've got to see how I get my screen here in presentation mode.
Looking good.
Okay, you're great. Okay, great. Everyone can see that?
Yes, it's good.
So I just want to start by saying thank you so much for having me. It's such an honor to be here as an economist, to be here among these amazing researchers and advocate for women's health. I'm here to represent HER-BC, which is a project that's been ongoing for the last year and a half in an attempt to understand the experiences of women in British Columbia who with menopause, both with health and their work. It's such an amazing topic to work on as an economist. It's understudied, but I think just like everybody else has suggested that it's become of more and more interest over time. And I'm hoping that this work will inspire other economists to take on this work and really help us understand the connection between menopause and workplace experiences, productivity for individuals, but for us as a society as a whole. So we're very lucky because the project has a video that they've created to help introduce the report. By the way, the report, I'm going to share a QR code at the end, but I believe that it's being shared in the chat at the moment. I hope that after you listen to me today, that you can take the time to look through the report. I can only talk about a few things from the economics perspective, but I think there's so much there that would be of value to everybody. So let's just take a minute and watch this video.
Women in British Columbia are facing a health crisis, and it's happening in silence. It's impacting every aspect of their lives, from their physical and mental health to their homes and workplaces. The cause is something that will affect almost everyone assigned female at birth: menopause. In North America, the average age for reaching menopause is 51, but symptoms can start a decade beforehand. In some cases, women may reach menopause even earlier. When you think of menopause, you might picture hot flashes. But in reality, many women experience a wide range of symptoms that often disrupt their daily lives, including their ability to work. The problem is that we don't talk about menopause. The stigma and silence surrounding women's health and aging are costing women not only their mental and physical well-being, but also their careers. That's where the HER-BC study came in. We surveyed over 2,000 British Columbians between 39 and 60 to better understand the impact of menopause symptoms. Many women felt unprepared for menopause and felt the topic is often dismissed, avoided, and misunderstood, leading to symptoms going unaddressed or untreated. Along with lack of awareness, women named other barriers to care, including access to doctors, adequate health coverage, financial costs, and geography. In our province, midlife women make up almost 20% of the workforce, yet many are missing days of work, cutting back on hours, needing to change jobs, turning down promotions, and even being fired. Overall, almost a third said that menopause had affected their job in some way. In British Columbia, overall poor health of women is estimated to cost the economy around $2.6 billion per year. And unmanaged menopause symptoms are likely to be driving these numbers. We also found that while 92% of those surveyed reported moderate to extremely severe menopause symptoms, 39% had not accessed any kind of health services to address them. So how can we better support women? The good news is that there are plenty of ways to manage menopause symptoms so that women feel supported to live healthy, active, and productive lives without disruption. Whether it's through medications, extended health services, or simply having access to the right knowledge and resources, workplaces can make a big difference. Right now, too many employers don't have policies and accommodations in place to support women during menopause. Women with private health coverage are much more likely to access extended healthcare services. On average, 3/4 of those who use these services reported improved symptoms. While employer health plans provide valuable coverage, there are opportunities to invest in plan design to better support the needs of midlife women. We must strive for better access to care. But first, we need to normalize conversations around menopause and recognize the realities many women face today. Public health campaigns can play a key role in raising awareness of menopause symptoms, giving women the knowledge they need to manage their health. We also need greater collaboration among and education for healthcare providers to ensure improved access and continuity of care. And in the workplace, we must create more supportive environments with structures that help reduce the stress of menopause symptoms and enable women to perform at their best. Without change, we risk moving further away from health equity for women. It's time to break the silence.
Okay, thank you. So as now I gotta get through my slides. Come on, there we go. So the HER-BC study interviewed and collected data from women across BC. So it's a BC specific study, but I think it applies to women across Canada. Other research has found that untreated symptoms of menopause cost the economy about $3.5 billion a year, with almost a $250 million lost to productivity. And what we find is that stigma, lack of education, a lack of awareness are all contributing to problems that women are experiencing in the workplace, in their relationships, in terms of their mental health, caregiving, and physical health. And all of that is being made worse by the level of misinformation and silence on this topic, which we've talked about so many times today, and it's just so important. As I start, I wanted to start with this is because midlife women have changed so much over time. Like the women who are midlife now are very different from midlife women in previous generations. I want to start by introducing what is the typical midlife woman today. So if you're a 50-year-old woman today, you are among the first generation of women for which working throughout your life has been very normalized. You are among the first generation of women that obtained university degrees at higher rates than men. And what that means is for women in their 50s today, not only are they better educated than women in previous generations, but they're actually better educated than men the same age as them. If this woman had children, because she had access to maternity leave benefits, it was easier for her to return to the workforce while those children were still small. And what that means is that midlife women today have a lifetime of accumulated on-the-job training and work experience. At the same time, because this woman's parents had fewer children than previous generations, that woman has a lot more responsibility for taking care of her parents than she might have previously. And because she had her own children later, those children are still quite young. And even when those children reach their 20s, as many as of us are finding out now, they still need our care. One of the things that I found really interesting with the HER-BC study is that 1 in 10 of the women that we surveyed still had a child under the age of 5. And this is fairly new for this generation because people are having their children so much later. So I start with this to say that it's really, really important to remember the contributions that midlife women are making. They're making to the workforce, they're making to in terms of unpaid caregiving and to the overall health of the province. And I'm going to return to this at the end because I think it really speaks to the importance of spending some time trying to understand the experiences of midlife women in the workplace and see what we can do to keep them in the workplace. Because one of the things that comes out of our data is that we are losing women because of menopause symptoms. In this chart that you have in front of you here is just to show the contribution that midlife women are making. More than 1 in 5 workers in this province is a woman between the ages of 40 and 65. 48% of workers over the age of 40 are women. And the contribution of midlife women is almost as great it is for younger women. We are not our grandmothers. We're not even our mothers. We are still very actively engaged in work, and we bring a lot to that. So I'm going to talk about some of the economic results. I'm not going to have as much time as I would have hoped, but I'm going to talk through and just show you some of the economic results that we're seeing in this data. First of all, as alluded to in the video, we had the survey that we did had multiple stages. We recruited people to our study. Of course, I don't know if you can hear my dogs barking, but of course the mail is delivered like right now. We recruited women to our study. Then we had an online survey where we had over 2,000 people respond. It's a very well documented. And then we had a second phase, which you're going to see some of here, and you saw in the video, where we interviewed participants and we were able to get some qualitative data from them. We looked at menopause symptoms and see how women were rating them. We found that 92% of participants reported at least one menopause symptom at a moderate to severe level. Sleep problems had the highest number of respondents with 68%, and 74% reported feeling tired or worn out. So here's from our interviews. This woman said, I'm just not myself. I don't like who I am, and I don't like who I've become. When we look at group differences, we don't find any difference by people based on race. So there's no difference between white and non-white participants. There's no difference based on health insurance coverage. And there's no difference in access to regular healthcare provider, but we do find a lot of socioeconomic differences. So for example, we find that people who are living in smaller towns as opposed to urban centers reported having scored more highly in terms of their menopause symptoms. We found that people who lived in lower income households, those whose household income is less than $50,000 a year, reported higher symptoms than those who lived in higher income households. We noticed that people who are educated reported higher symptoms than those with less education, but this actually might simply be a fact that people who are higher educated are more likely to recognize those symptoms as menopause symptoms. And we noticed that people who are working had higher symptoms than those who did not work. And then we find that the symptoms are higher among people who've already reached menopause than those who are in perimenopause. Okay, so looking at some of the work, and this is I think the most important thing that I have to say today, is that we look at those menopause symptom scores and how that experiences women in the workplace. So here we have the average scores on the vertical axes, and along the horizontal axes we have the work experiences. So for example, if we look on the left of the graph, you can see that the menopause scores of people who declined a promotion are much higher than those who did not decline a promotion. And this is true across all of these. They were higher scores for people who worked fewer hours, reported that their job was affected, that they'd left their job, that they'd lost their job, or that they missed work. Turns out that 1/3 of the people surveyed said that their menopausal symptoms were affecting their experience at work. 1/4 reported missing days of work in the last 12 months. 17% reported cutting back on their hours. But here is where we get into what I actually think is very concerning in the data, is that 1 in 10 women reported that they turned down a promotion or other type of opportunity to advance their career as a result of their menopause symptoms. You know, given that midlife is when most workers are promoted to senior leadership positions, these number of women who are turning down promotions or quitting or losing their jobs due to menopause symptoms, it could go a long way to explaining why women in this country continue to be underrepresented in political, professional, and leadership roles. And a particular concern is that in our data, 17 people, and this may not sound like very much, just 1% of our sample, 17 people reported that in the last 6 months they were fired or laid off because of their menopause symptoms. And I think this is something that should concern all of us, that given that there are literally millions of women in this country working at this age, there could potentially be thousands of women who are losing their jobs for health concerns that, according to the Accessible Canada Act, meet the criterion for a disability. I'm not gonna have a lot of time to talk about recommendations at the end, but one of the things that I think really needs to come out of this report is the importance of understanding both these work experiences and the obligations of employers to their midlife women workers. So here's some quotes from the survey. Said, the big one was not being able to concentrate. The brain fog was huge because I felt so unsure of myself. And then the whole fear of making a mistake. And that's when I knew it's like, you know what, I'm just taking too long. I'm not confident in my practice. This other person said, I'm just tired of not feeling good. It's impacting my success at work. Another thing we found is that a lot of our participants were experiencing mental health symptoms. Almost 10% scored severe in all 3 sociological scales: anxiety, loneliness, and depression scores. And also we found that anxiety, depression, and loneliness all significantly and moderately correlated with the severity of symptoms, as well as other degrees of bother. I'm going to have to skip through, sorry, because I'm running out of time and I want to make sure that I hit all the work points. But in terms of mental health and work, I think that one of the things that we find, and this is supported by other research, is that we know that the menopause symptoms affect anxiety and depression. Lots of research has found that people who experience anxiety and depression struggle at work. They struggle in terms of absenteeism and presenteeism. At the same time, there's this growing literature on loneliness, and we know that menopause symptoms are contributing to loneliness and a sense of isolation, and that those symptoms in turn are affecting their productivity at work, and causing them to not only be less productive, but often leave the workplace. So all of these 3 things, both separately and interconnectedly, are interfering with people's productivity. But then the cycle goes back, and women start feeling like a failure. They feel like they're struggling with their cognitive abilities, and that just heightens a sense of loneliness, depression, and anxiety. So I'm sorry, I'm going to have to skip some of this because I really do want to talk about some of the workplace. One thing we found that is somewhat heartening is, first of all, we find that women who experience are able to access extended health insurance, are able to uh, see others for treatment, get treatment for their symptoms. And we know that people who have access to workplace health experience insurance in particular are way more likely to have some of these negative outcomes that I've already discussed. So for example, on this chart, the top line is people who have no health insurance. That's green if you can see color. The purple line is people who have employer-supported health insurance. And so we see that people who have employer-supported health insurance are less likely to reduce their work hours. They're less likely to decline a promotion. They're much less likely to quit their job. The only thing that we find is that they're more likely to miss days of work. But I think all of this suggests is that workplaces that have health insurance are also the same type of workplaces that offer workers paid days off work. I think I'm actually out of time. So if I can just say one more thing, that would be great. Sorry, Shirley. And so I want to end with this, is that when we think about supporting women in the workplace at midlife, we might want to do it because of a sense of equality and wanting to help individual women, but I actually think it's really important to know that when we help women stay in the workplace at midlife, we all win. We win as a society. We end up with a larger, more productive workforce, especially given that these women bring all of these skills and education, years of work experience to the job. We end up with more women in senior leadership, which is important because we know that firms that have gender diverse leadership are more productive, but we also know that firms with gender diverse leadership are way more supportive of women of all ages. And gender diversity is being shown as one way that we can experience economic growth without making any other changes is really quite effective. We have fewer women living in poverty when we support these women because they're able to work longer, they're able to accumulate more savings, access more years in the Canadian pension plan. And this enables senior women to live more independently. And then it allows women to continue to contribute to the unpaid caregiving that we do, making families more resilient. Okay, so I'm sorry that I have to stop there. Here's our recommendations. I really encourage you to take a look at the report and see what we recommend for addressing so many of these issues.
Thank you, Dr. Ashade. I am so grateful that there is an economist who is delivering these messages, because that it's usually either at the organization wallet level, but also at the personal wallet level, where some of these experiences really hit us hard. And so I've been thinking about this since November 1st and talking about it every day. As an employee who's listening in today, and we still have many people with us, which is I'm so grateful for as well. As an employee who might be listening today, what is one thing that we can do that might be within our sphere of influence?
Oh my gosh. So you mean midlife employees or just all employees?
Well, women who are listening to this thinking, yeah, this all sounds great. Thank you very much. But my employer, blah, blah, blah. And so I really like to kind of turn the mirror on ourselves and say, okay, thank you for the research. What can I do today?
So I think the one thing that we should all be doing is having more conversations at work, even if it's just water cooler conversations. I think that having conversations reduces stigma. It helps people find resources that they might need to educate themselves. And then, as I already said, I think one of the things that's really missing in so much of the conversation we've had is what are the responsibilities of employers to their employees to accommodate people who experience menopause symptoms, and what are the rights of individual workers. And I think that the best way we can communicate that, we like to talk about public health campaigns, and I think this is all great, but so much conversation is communicated just through talking in the workplace, just talking to each other, finding out what is going on and what is possible.
Yeah, that's great. And to remember that we do have a voice, even at the water cooler, and that it could be our sphere of influence, and it could make a difference to someone else's life too.
Yeah, absolutely.
Yeah, thank you so much. I'm curious, have you gotten any feedback from your fellow economists this week since the report was released?
I have not. I think this is for them, this is kind of flying under the radar, but I am bringing it up in my classrooms. I teach 2 large classes, and it's funny when we think about the next generation, we think they might not be that interested in it, but actually they're more interested in it than anybody else because their mothers are going through this. And when I speak to them, especially when I talk about discrimination against older women workers, which I didn't have much of a chance to talk about today, a lot of them will come to me and say, my mother is experiencing just this. She lost her job, she could not find another one, and those types of things. So I actually think the next generation is very interested in this, more than we might anticipate.
I agree. I see that all the time. Thank you so much for your time and your expertise and for interpreting this data for us. Research sometimes gets misinterpreted as the end, and it's actually the beginning. So we have a lot of work to do. I'm going to welcome our fellow presenters back. If you are able, we are probably going to go about 10 extra minutes today, if you can afford that time. And I have gone through the Q&A, of which there has been a lot of engagement. Thank you everyone for your questions. Some of them are very personalized, as we mentioned, and we may not be able to give you that individualized response, but I have noticed some themes. Maybe our presenters can raise their hand if they want to speak to that. Some of the themes have been around, not surprisingly, hormone testing, testosterone, breast cancer, cholesterol, and finding a doctor, or the lack of healthcare access that we have in this country. So maybe Dr. Yüksel, I can begin with you. This question came in while you were presenting, and it was around the question of testosterone and testosterone hormone therapy.
Yeah, thank you. And I just wanted to mention, I just really enjoyed everyone's presentations today. So I thought it was really great. Testosterone's in it. Yeah, that's a good question. And I know there's a lot of interest. You'll see a lot on social media about testosterone, and should, everybody be on testosterone. In my practice and the menopause clinic that I worked in, we did use testosterone in certain, populations. For example, in women who've, had a surgical menopause where, ovaries removed, and they needed the testosterone to help with, some of the low libido and some of the other symptoms. We do also use it for some postmenopausal women and for things like low libido, but it's usually after we've tried hormone therapy already and they're still continuing. And I mean, libido is a much more complicated thing than just looking at testosterone. So I think it's getting it fully assessed and looking at all the reasons, but you may see it in some population. But does everybody need to be on testosterone? No, I wouldn't say that. And a lot of the guidelines are stressing, that it shouldn't be on everyone, but maybe in select populations, it might be an option.
Amazing, thank you. Dr. Lega, the question comes up often every day in the work that I do around testing hormones. And so as an endocrinologist, I can only imagine that we need to explain hormone testing exists for a reason, but yet that often gets misinterpreted when it comes to social media. Can you respond to that, please?
Yeah, absolutely. I mean, as I said, menopause is a normal and natural transition. So when a woman is in her 40s and 50s and is experiencing the changes we know are menopause, there's really no reason or benefit to confirming that with testing. So as I tell my patients, I mean, it won't change my clinical practice. It won't change what I recommend for you or what I suggest to you. So those are tests that aren't worth doing. It really doesn't add any value. So if you're having night sweats and you're having hot flashes, I don't care if the FSH is normal or not. I'm going to treat you for that symptom, given that you are in this period of your life where I know this is perimenopausal. The perimenopause is another time, and perimenopause really refers to those 10-ish years prior to menopause. So mostly women in their 40s, given that the average age of menopause is 51. And that's another time when really there is no real value, no clinical indication to check hormones because it doesn't change management and doesn't give you any clarity on what's going on. So it's a struggle though, because a lot of people, I don't know, based on perhaps what they're reading, perhaps different types of providers where testing is much more common, really push back and feel like I'm not providing them with best care because I'm not doing that. And again, I have to sort of explain how as MDs and physicians, our practice is really, we do a test to find something that can change our practice. And if it doesn't, there's really no value in doing it. But it's a struggle.
Did you want to add to that, Dr. Yuso?
I think that was a really good answer, and I think I might have answered a little bit too in the question and answer when afterwards. So, but no, that's a great answer, Dr. Liga.
Amazing. Luana, we got a lot of compliments and feedback about the research project that you led. And then the question came up, and anyone can respond to this. What other, we know there's a shortage of research in women's midlife health in Canada. What other research projects are on the docket in Canada, and what can we look forward to? You can all leave your mics on if you want to. And the specific question was, is menopause hormone therapy currently being researched in Canada?
Shirley, what was the question? Is
It was
that any of us?
Yeah, the general question, overriding question is, what research is currently happening in women's midlife health in Canada? What can we look forward to? And specifically, is menopause hormone therapy being researched in Canada?
Yeah, that's a very good question. And already you've heard some great work from the HER BC and Luana's work as well. So these are all fascinating. There's lots of different types of research happening across Canada in different areas, looking at there's a group looking at a database to be able to collect and continue to look at cohorts of women and what's experienced. So types of hormone therapy that may be started, or other options, non-hormonal options that may be started, in some of the outcomes. So some of that work is happening, and there's a good group across Canada that's looking at that. There is work that we're looking at menopause curriculum, for example. It's something that we've talked about too. So lots and lots of different pockets of great work across Canada. It's hard to summarize all of them, but yeah, it's great to see some of them today.
Yeah, thank you. And I think if I was to respond to this individual's specific question, is that we do have solid research from every menopause society in the world around menopause hormone therapy. So we can refer to that via the Canadian Menopause Society and the North American Menopause Society, now called Menopause Society. How many times do I say?
Confusing, right, Shirley?
Let's go to something else that is a barrier in Canada. So we talk about the lack of research. We also have lack of access to care. I think last number I heard is 7 million Canadians without a primary healthcare provider. What can we recommend to individuals who may not currently be attached to a family doctor when they are trying to navigate their perimenopause to postmenopause journey?
That's a tough one.
I know.
I think first, I just do want to stress that for those that do have a primary care physician and are attached to one, they really should try to engage their primary care physicians first and foremost. I think that's very important. And I gave you some suggestions earlier on to really create a learning environment with your primary care physician if they aren't in tune. If you don't have one, obviously look for one. And I know that's easier said than done. I mean, I know at least in Toronto, but some of these clinics, there are clinics sprouting up that are menopause clinics, and some of them are able to do virtual care across the province and across different provinces. Now, is this a solution? Sort of. I have some concerns with these clinics in general because it doesn't negate the need for a primary care physician to guide you through the changes beyond hot flashes. I think these clinics, and many of them haven't even started yet, hopefully will be good at addressing symptoms of menopause. Hopefully they will be able to do that in a way that works well. But the whole other changes we talked about, the cardiometabolic risk, just really optimizing your lifestyle in general and just leading you through life beyond menopause will not be addressed by these clinics. Also, they're very expensive. All these clinics are out of OHIP, unfortunately, which is their businesses again. And so anytime you get into the business of menopause, you have to always, I think, ultimately be a little bit careful. But certainly that could be an option for someone who's really having significant symptoms and has no other way. I think the other way too is we do have walk-in clinics, and there are menopause clinics or people with menopause expertise. So going to a walk-in clinic and asking for a referral is not ideal, but for someone who really, really is not connected to a primary care physician, that might be a reasonable option to access sort of quality menopausal care. I think those would be the solutions I think about.
I was just going to mention about if you are accessing, some of the walk-in clinics or even with your own primary care provider, there is resources online that you could access. And so one really good resource that's has been developed is called MQ6, and we can send the link to MQ6. And it was developed by a family physician, Dr. Susan Goldstein, who's on the board of directors of Canadian Menopause Society as well. And so it's a really great algorithm. There's a section for women as well, and they can kind of go through the algorithm and see if they have symptoms or what options might be available, and then bring that to their primary care provider. The other thing I want to mention is looking at all different health disciplines that can also provide support for different things. So is it a nurse practitioner, nurse, pharmacist? And I thought that was interesting to see all the ones that are being, all the different health providers that are being used. I think in the she/her, Marina, you had mentioned like some of the resources that people are using as well. So just thinking more broadly about all of this as well.
That is all great and valuable advice. Thank you so much. We are getting the time call, which I can appreciate. The Q&A is full. That won't be a surprise to any of us here, but hopefully you have benefited from the time that you've spent with us and our experts today. And take those questions, experts, as a compliment, because really it means that we have even more interest and more engagement, and we've ignited more curiosity around the topic of misinformation, especially as it relates to menopause and women's midlife health. So thank you for inviting me to play a role in this event, and I am going to turn the microphone back to Tamil. Thank you so much, Tamil.
Thank you so much, Shirley. And a huge thank you to all of the presenters for sharing their expertise, to all of you for being here. And as I noted in the chat, we will send out the links that have been requested that different of the presenters shared in an email to all of you, and also the link to this video, to this Zoom recording, will be available for your reference on the POWER website. So again, thanks to all of you for sharing your expertise, for sharing your questions, for being so engaged. And I also really want to thank both the POWER partners, the research institutes, and the Women's Health Collective Canada, our sister organization that makes us possible to highlight the amazing knowledge that is being generated in Canada that can benefit the health of women, trans, and non-binary people. So thank you all, and have a fantastic rest of your day.
Thank you.